Chalo chodo. The most important topic, that is your diabetes mellitus. It is hyperglycemia. We are doing four tests. The blood sugars fasting, blood sugars, prandial blood sugars, that 2 hours after the food, HbA1c and random. Now, any value of less than 99 or equal to 99, fasting, normal. 100 to 125 pre-diabetic, more than equal to 126, this is diabetic. 2 hours after food or random, they are having same values till 139, it is normal. 140 to 199, it is pre-diabetic, and more than equal to 200, it is diabetic. HbA1c of any value less than equal to 5.6, normal. 5.7 to 6.4, pre-diabetic, and more than 6 equal to 6.5 is diabetic. Then random to same hai. For any value, even out of these four, any one value falling in this category requires treatment. And anyone who is in this pre-diabetic range requires no treatment, no drugs, nothing. Lifestyle modification can help. Now, blood sugars in our body, they are maintained by insulin and glucagon. Both are secreted by the pancreas. Pancreas have beta cells, alpha cells. Beta cells of the pancreas, when the glucose is high in the blood, beta cells will secrete insulin. Insulin will take this glucose into the peripheral cells, hence reducing the glucose levels. Alpha cells, when the patient has low glucose, alpha cells will secrete glucagon, and glucagon will cause gluconeogenesis and make glucose. Now, these beta cells also secrete one hormone, that is amylin. When they will secrete it? When the glucose is high in the blood. And this amylin will block the glucagon secretion. So your increase in blood sugars, they're actually controlled by insulin, but indirectly controlled by amylin. So there are not two, but three hormones coming from the pancreas. But major two are insulin and glucagon. Pancreas is exocrine, endocrine both. How are we managing the blood sugars? So whenever you have eaten food, you have glucose more in the blood. This glucose enters into your beta cells via GLUT2, giving the ATP. This, with the help of this ATP, your beta cells will block the potassium channels. These potassium channel generally is pushing the potassium out of the beta cell, but now you have blocked it, so potassium will become more inside the beta cell. This more potassium will increase your calcium channel. They will open the calcium channel so that you can take the calcium inside. This more calcium influx will help in insulin release, but this only calcium is not enough to cause the insulin release. The second thing which you require for insulin release is GABA, which you are getting from glutamic acid by the enzyme glutamic acid dehydrogenase. Okay. Now, for insulin release, two things are required, calcium and GABA. For opening of the calcium channel so that you can take the calcium inside, you require again two things, the potassium and HNF1 alpha secreted by the nucleus of the beta cell. So once your insulin is released, it goes in the blood, does not do anything with the glucose. It directly goes and attaches to the peripheral cells over your, peripheral receptors over your peripheral cells. So now these peripheral insulin receptors which you have, they bind with the insulin and they give the signal to GLUT4. The GLUT4 opens and your glucose comes inside, and that is how you put the glucose inside for future use, and you decrease the quantity of glucose inside your blood. This is how normal metabolism is occurring. Normal glucose metabolism is this. Now we have four important types of diabetes: type 1, type 2, MODY, and LADA. Now type 1 is autoimmune, wherein the we don't know why, but there are antibodies which are formed against the beta cells. So islet cell antibody or against the GAD enzyme. So you'll not get GABA. So anti-GAD antibodies or against the insulin, anti-insulin antibody. Now these antibodies, they will activate the immune system, call the T cells, and T cell will come and destruct the beta cell. So in these patients, you'll not have insulin because you're not having beta cell, and these patients are called as type 1 diabetes or insulin dependent diabetes mellitus patients. Okay. In type 2 diabetes, what happens is there is no problem with the beta cell. In type 2 diabetes, due to XYZ reason, when the insulin comes and binds with the insulin receptor, the signal which has to be given to GLUT4, it is not given because your insulin receptors, they are not working proper. So there is no shortage of the insulin. So giving insulin will not help in these patients as such because you're not able to open GLUT4. That is why you're not able to take the glucose in. And this glucose will never go inside because the GLUT4 is not opening. So you need to give oral hypoglycemics to break down this glucose and It is not dependent on insulin at all, so therefore it is called as insulin resistant diabetes. Okay, so type 1 में प्रॉब्लम क्या है? इंसुलिन की कमी हो रही है बिकॉज ऑफ एंटीबॉडी, सो दैट इज व्हाई इट इज कॉल्ड एज इंसुलिन डिपेंडेंट. और टाइप 2 के अंदर रिसेप्टर काम नहीं कर रहा है, दैट इज व्हाई इट इज कॉल्ड एज इंसुलिन रेसिस्टेंट. ओके. There is one more type of diabetes which is called as LADA, latent autoimmune diabetes of adult, because the word is autoimmune. So LADA behaves like type 1, and that is why it is called as diabetes mellitus 1.5. And there is the fourth kind, MODY, maturity onset diabetes of young. It is due to defect in its HNF alpha. Now, HNF alpha, if it is not there, what is the requirement of HNF alpha? HNF alpha requirement is to open the calcium channels. अब जब HNF1 alpha नहीं है तो calcium channel खुलेगा नहीं. So what you have to do? Do not think that you have to give insulin to these patients. No, insulin है. You just need something so that this insulin can be released. Now, you have two hands to open this calcium channel. What are the two hands you have? Potassium and HNF1 alpha. If you do not have one hand working, you apply more power from the second hand. So you give potassium channel blockers in MODI. So between type 1, insulin. LADA, insulin. Type 2, oral hypoglycemics, जिसमें metformin वगैरह सब आएगा. And in MODI, the answer is potassium channel blockers, sulfonylureas. Okay. Now this is what is the pathogenesis of all these diabetes. ठीक है भाई. Now let's see that what are the differences between them. So, beta, for differences between them, see, type 1 diabetes, beta, it is seen in young. The age is less than 25, I've written, but it is very young people, you will see this type 1 diabetes mellitus. Type 2 is called as lifestyle diabetes, so it is generally seen post 40 years of age. And all those metabolic syndromes like, obesity, hyperlipidemia, hypertension, all these, they predispose to type 2 diabetes. Okay, it's the most common type of diabetes. MODI, again, less young, hai na? So less than 25. This is generational diabetes, autosomal dominant in inheritance. And LADA, it is diabetes mellitus 1.5, but it is not, happening like diabetes 1. Diabetes 1 is happening in very young people. But at ye LADA, it is not in that young people. So it is seen after 20 years of age. LADA. But type 1 diabetes 5 साल के बच्चे में भी दिख सकती है, 10 साल के बच्चे में भी दिख सकती है. The pathogenesis of type 1 is autoimmune, you know. LADA also is autoimmune, you know. Type 2 के अंदर you will have insulin receptor dysfunctioning, and MODI के अंदर HNF1 alpha defect. All these metabolic syndromes, they are associated with type 2 only, and there is a massive beta cell destruction in type 1. In type 2, because you are not able to open GLUT4, so continuous pressure is on beta cell to secrete more insulin, more insulin, more insulin, whereas this insulin is not working because there is no problem with the insulin deficiency. There is a problem in the insulin receptor. लेकिन अब वो बीटा सेल ओवरवर्क करता है, दैट इज व्हाई बीटा सेल विल बी less, but not as much less as type 1. MODI के अंदर beta cells remain normal, and LADA में भी because destruction will be happening, but slow destruction, so beta cell at the time of diagnosis will be less. But in type 1 में तो खत्म हो जाता है. ठीक है. At the time of diagnosis, I told beta, this type 1 diabetes mellitus can be seen in 5-year-old kid, 7-year-old kid. तो आप सोचो 5-7 साल के बच्चे में 80% of the beta cells are gone. So severe this is. Okay. Diagnosis के लिए random blood sugars anywhere more than 200, because till 199 is pre-diabetic, so more than 200 तो ये डायबिटीज हो जाएगी. OGTT में abnormal OGTT डायबिटीज में मिलेगा. HbA1c glycated hemoglobin, that's the best test because it gives us 90 to 120 days of blood sugar level. Glycated hemoglobin is glucose which is bind with the RBC, and RBC lifespan is 90 to 120 days. It can come false high in some patients because if a patient is in anemia, let's say, so RBC count of the body will be less. So a glucose binding to RBC will be more because there are less RBC in the body. So false high मिल सकता है कई बार. ठीक है. What are the complications? It can be microvascular complication like retinopathy, neuropathy, nephropathy. तो रेटिनोपैथी में तुमको पता है न्यूवास्कुलराइजेशन, माइक्रोएनेरिज्म. नेफ्रोपैथी में अपन ने बात किया बेटा कौवा लीजन. Then macrovascular complications like peripheral vascular diseases, ischemic heart disease, cerebrovascular accidents. And non-vascular में क्वेश्चन बहुत बार आ चुका है, म्यूकरमाइकोसिस ड्रग ऑफ चॉइस, दैट इज एम्फोटेरिसिन बी. एंड कैटरैक्ट एंड ग्लूकोमा तुमको पता ही है. व्हाट इज द कैटरैक्ट विद डायबिटीज? स्लो फ्लेक कैटरैक्ट गिविंग यू हाई सॉर्बिटल. When you are treating these patients, now treatment of these patients, what is your goal? But your goal is very simple. You are not supposed to make the the glucose level come in the normal range, because if you're trying to take the glucose in the normal range, you are giving you are getting too harsh on the patient. No, please don't take me wrong. I'm not saying that you cannot take the sugar to the normal levels. You can. But the problem is that if you go too harsh and you try to control too much of sugar in that patient, there's a risk of hypoglycemia. Now, why I do not want anybody to suffer from diabetes? Because hyperglycemia can cause complications. But these complications take years to happen. Whereas one single episode of hypoglycemia can take patient's life. So we are just trying to avoid the complications. So we have seen that if we take the fasting blood sugar levels to less than equal to 125, or PP less than 180, or HbA1c less than 7, we avoid the complications of diabetes. So that's our target. For type 1, as I said, we give insulin. For type 2, as I said, oral hypoglycemics. For MODY, it will be potassium channel blockers. And for LADA, it will be insulin. Again, because LADA is as type 1. So first, let's talk about oral hypoglycemics. There are six classes of oral hypoglycemics, which I'll tell you, and then the insulin. First class, metformin, you all know, drug of choice for type 2 diabetes, and it is the first line drug. The only problem is that it causes lactic acidosis and vitamin B12 deficiency. And if it's a renal problem the patient having CKD, stop metformin. Okay, you can't give it. Then second is sulfonylureas or bigonides. They are one of the best after metformin, but they have a problem. They have a risk of hypoglycemia and they cause us weight gain. So we have to, take care of that. Then, and they are the drug of choice for MODY actually. Then you have SGL2 receptor blockers. Now your 100% of glucose from the urine is being absorbed by PCT because there is SGL2 receptor over there. Now, in these patients, already in the blood, I have too much of glucose. So, why I want to absorb the glucose from the urine? I block these channels, SGL2 channels, over the PCT so that whatever glucose is going in the urine, it goes out. The only problem is these patients will have glucosuria, that's okay, but glucose is a very good culture media for bacterial growth. So bacterial growth can occur and patient can have UTIs. The name of the drug is glyphosate. They also do not have any risk of weight gain. They do not have any risk of hypoglycemia. Then you just learn this GLP-1 receptor agonist, a very important drug. This is the third most prescribed drug in the diabetes patient. The first drug we are using is metformin, second are sulfonylureas, and third are GLP receptor agonists like exenatide. Why? Because they are very, very beneficial in a patient who is having a cardiovascular disease risk. Okay, तो ये याद रखना हमेशा. And it also doesn't cause weight gain or hypoglycemia. Alpha glucosidase inhibitor, but this drug acarbose. Now, any patient who is having problem with postprandial glucose, let's say. So whenever the patient is eating, the glucose is being absorbed, and then afterward, this glucose is, not settling properly. So if I just want to take care of postprandial glucose with metformin, I will give alpha glucosidase inhibitor because it does not allow the glucose from the stomach to be getting absorbed. Okay. The only side effect is flatulence. And then you have amylin analogs. These amylin analogs, beta, you know what is amylin doing? It blocks the glucagon release. It decreases the satiety, and it increases the satiety and it decreases the appetite. So the patient will always feel that I'm okay. I do not want to eat, so sugar levels will not rise. Okay. For HbA1c reduction, मैंने तुमको पहले भी बताया, best drug is metformin, second is sulfonylureas, and third are GLP-1 agonist. Then, if anybody is having diabetes and is showing complications, it's very important for us to remember that anybody with complication we have to start insulin. Does not matter it is type 2. Type 2 में मैंने बोला इंसुलिन का कोई काम नहीं है, but it is seen that sometimes when the complication is too much or the drugs are not managed to under this to keep the HbA1c levels in check, insulin can be given in these patients. With different kind of patient risk, you can add other drugs with metformin, like in atherosclerosis, GLP-1 receptor agonist and SGL2 receptor blocker is a very good. Heart failure may be SGL2 receptor blockers, and renal diseases, kidney diseases, liver diseases, SGL2 receptor blockers can be seen. Just give me a second. Okay. Then insulin. But insulin, it can be of two types, the basal and the prandial insulin. Basal insulin 24 hour तक रखना है. Best insulin we are giving is glargine. which is checking our basal insulin to 1 day, so 1 shot per day. Deglutec भी ले सकते हैं, 1 shot in 2 days. Parental insulin, it is before meals, and we are using rapidly acting insulin because insulin has a chance of going into hypoglycemia. If you take regular insulin, you have to take it 40 minutes, 30 minutes before the food. So, more chances of getting into hypoglycemic episode. So, you just take 10, 15 minutes before food and you're okay to go. This and aspart. Complications of diabetes mellitus, dawn and somogi. In dawn, the patient is taking less insulin than required, so patient will end up in having very high fasting glucose in the morning. So increase the dose of insulin in these patients so that this complication doesn't occur. And somogi phenomenon, in this the patient is taking more insulin, so patient goes into hypoglycemia during the night, but still the cortisol will work to save the patient and you will have little bit fasting glucose more. So in these patients, decrease the glucose, the insulin the patient is taking at night. Not much. But DKA and HHS, they are very important. DKA more commonly seen with type 1 patients, more commonly. What happens is that the insulin is not present in these patients. So the glucose is not entering inside the cells. And if the glucose is not entering inside the cell is not getting the energy. But liver activates. It breaks free fatty acid via beta oxidation into acetyl coenzyme. And this is acetyl coenzyme will form ketone bodies. These ketone bodies, they will give energy to the cell. So cell is alive. Cell को कोई problem नहीं हो रही. But these ketone bodies are very acidic. And when they come inside the blood, they make the blood acidic, metabolic acidosis. Hmm? And because you are not utilizing glucose for the energy, the patient is having too much of glucose in the blood. This too much of glucose will lead the patient to go into polyuria and the patient will get dehydrated. So dehydration plus metabolic acidosis, both things will be seen in the patients of DKA. How do you see metabolic acidosis? Vomiting, nausea, increase in respiratory rate, very deep inspiration, small breathing. And because these ketone body, one example is acetone, which has a fruity smell. So these patients are labored breathing करते हैं बहुत deep. So fruity smell can come. Okay. If you check, blood glucose level will be very high. Urine ketones will be seen obviously. Sodium नहीं मिलेगा. Patient is polyuria ना, तो blood में sodium है ही नहीं. Plus ABG में H will be more. Acidosis हो रही है patient को. So H ions will be more in ABG. Treatment, give the IV fluids in these patients. They are dehydrated patients. Give insulin IV. IV insulin beta. Okay, and what is the rate? This rate you have to learn. 0.1 international unit per kg per hour, because if you do rapid correction, then it will cause cerebral edema. And you give KCl. What is KCl? Potassium chloride. देखो, insulin and potassium inversely proportional. So if you're giving insulin in the blood, potassium will go inside your cells and the patient will have hypokalemia. Hypokalemia is a problem. So what we give potassium also. So that patient does not go into hypokalemia. Like hyperkalemia can cause arrhythmias. Hypokalemia can also cause arrhythmias. तो पता चला आपने डीके तो ठीक कर दिया, बट पेशेंट हैज गॉट इरेगुलर हार्ट रिदम, खत्म हो गया पेशेंट. गिव केसी. HHS, this is hyperglycemic hyperosmolar state. It is more commonly seen with type 2 diabetes mellitus. Patient is old in this scenario, dehydrated because not drinking too much. So H2O is less, ions become more in the blood, blood becomes hyperosmolar. Now the osmolality is very high. Patient is having concentrated blood, hyperosmolar blood. Now when this blood flows into different organs, it draws out water from the cells of the different organs and the cells of the organs will die. Patient will have massive multiple organ damage, very severe. This is more severe than DKA, HHS. Okay. So patient can have multiple organ damage, same treatment. No difference, same treatment. In DKA, sugar levels will be high. HS may be high रहेगा, but HSS has more sugar levels at the time of diagnosis. pH, obviously acidosis हो रहा है, तो pH will be less here. Ketones will be seen in DKA, nothing here. Anion gap यहाँ पे मिलेगा बेटा DKA में. ठीक है, you will see an ion gap. And serum osmolality of these patients can be anything depending upon the state of the patient. But hyperosmolar, hyperglycemic state में तो बताइए hyperosmolarity होती है, तो too much of ions will be seen. Okay, this is the difference. And now, just last thing, for the tumors, I will tell you the tumors which are high probable chances of coming in the exam, and that is your men. ठीक है, men 1, men 2, A2, B and men 4. डायरेक्ट याद करेंगे छोटू. पिप्पा E, पिप्पा G, पंपा PMM. ठीक है छोटू. Men 1, 1 तो it is वर्मर. Men 2 तो सिपल. ठीक है. The enteropancreatic tumor, which you see with men 1, most common is insulinoma in this, not gastrinoma, it is insulinoma. All right. So you just remember this whole thing, pipai, pipaji, pampa, PMMM, काम चल जाएगा, and remember the insulinoma. So this is the entire discussion of diabetes plus the endocrine tumors. And with this, I finish with all the revision videos of your medicine topic. I hope these videos will help you in quickly revising things. Just listen to me and just keep seeing in your workbook. And after that, just learn it once yourself and you'll be good to go. Take care. Bye bye.